Prashant Pavan sir and the team ARC for this wonderful opportunity. So my topic is initiation of clinical learning. And so through this talk, we would be at the end we would be defining the specific goals and what would be the outcome to how we would be initiating these clinical learning, especially for residents, trainees and the fellows. So why exactly is this topic? When I got this topic 3 days back and I went through few of the literature search, all the initiation of the clinical practices studies are in 1980s. It's only in the recent 2013s and 14s that there is a resurgence of the interest in this ophthalmic education. Why is it so? Because the curriculum has changed, the amount of knowledge and the technologies which we had been using has changed, and hence the inculcation of the various learning techniques have changed. And we need to include all the novel education strategies, especially after the COVID-19, when the patient education and the direct contact with the patient reduced. So one of the studies by Zhang H. said that most of the students said they were having teaching in the clinics in the form of lectures, but they preferred teaching in the form of hospital tutorials, which they actually had during their UG days. So then what the ophthalmology department did, he actually went through whole of the Australian 56 medical colleges. He did this change where he inculcated clinics-based live cases and demonstration of examination techniques by the subject experts. And what was the result? The positive impact was on the amount of knowledge. The average pre-test and the post-test scores changed from 40% to 76%, and this p-value is significant. So now this in Australia, what they did, they went around and they did clinics based on live cases. Can we do this in India became the next question. Well, most of the surgeries in most of the institutions as well as medical colleges have become a daycare surgery nowadays. Do we admit any patients? Well, that is hardly maybe 1 or 2 of the corneal ulcers which we get, or maybe post-op cases which we wouldn't let our fellows or postgraduates to touch them. So that is one point where actually the patient efficiency for the clinical learning. Second thing is patient demands and ethics. Lots of the patients who come to our OPDs now refuse to get touched or even examined by a junior doctor. They want themselves to be seen by the senior doctor as the first setup. So with these two barriers which are happening in most of the OPDs, how do we go ahead with the clinical learning? And that is where the newer technologies, newer advances of the clinical learning has come, and that is simulation-based education and the technology integration to help the children, especially our students, postgraduates, to learn. Research has showed that most of the medical students have skill retention of only 3 months post-training. So we have to increase this skill retention in them, and that is where the simulation-based education and technology integration has come. The first most important change which was brought about, all these changes are post-COVID changes minded, when the patient touching and the patient interaction with the patient went down. That is when technology got involved into the clinical learning. So there was something called as Zimbabwe Retinopathy Telemedicine project, which is done in most of the Indian scenarios also. That is, a person goes, he takes a photo, a trained academician goes, he takes a photo of the retinopathy of the prematurity and then he sends it. But these were being analyzed by the postgraduates and the fellows along with their assistants. So they used to see each and every ROP photos which helped them in the clinical evaluation, and later based on the MCQs which were projected for each of the ROP photos which were being taken in the periphery, they were analyzed within those 1 month of their training as to how the improvement happened, and this they called as Zimbabwe Retinopathy Telemedicine project. The second one is digital learning. Same thing has been done as a Gen ROP. This Zimbabwe ROP study has been included throughout the world as a global education network for retinopathy of prematurity, where this Gen ROP holds their own website where fellows and postgraduates can enroll themselves from any part of the world, and a mentor sits at the other side, mostly from the US or Canada, and a live discussion does happen with respect to case-based scenarios as well as the photos, where the students get to learn clinically as to what they are seeing and what would be their way of management if they see. The next is the virtual ophthalmology clinics. So what is virtual ophthalmology clinics? Where they get to see patients initially in virtual mode, the animations, the same clinical features what they would be seeing in a patient is being projected virtually. Followed by that, the MCQ start, and then when they answer, based on that the pre-assessment and the post-assessment happens. So the advantages are many. There is a digital enhancement, flexible learning opportunities. Multiple people from all over the world are sitting in that virtual ophthalmology clinic. So you get to discuss with multiple students, you get to hear their answers. there are 4 to 5 mentors of that specific subspecialty who are actually teaching you clinically that this patient may have this. So instead of just learning from one mentor, virtually they are getting to learn from 3 to 4 mentors sitting at home. But then what are the cons? There are multiple cons too. It requires reliable technology access. The distractions can be challenging to some learners and over dependency on the digital. There are some other cons which I'll come in the last part of the slide, last part of my slide. And then the virtual reality. So this is the newest one. When I actually searched through the internet, I realized my own subspecialty, that is for the pediatric ophthalmology or the strabismus, where a learning is difficult without being able to assess strabismus. There is something called a strabismus emulated avatar humanoid simulator. It is being designed by Korean and comparatively slightly expensive, but then those postgraduates or the fellows who can really afford it, it does let them do digitally how to perform a cover uncover test, how to do a prism based measurement of the strabismus, and then a third person view is also present where the teacher can sit and assess them if they are doing a cover uncover test perfectly or are they doing any mistake. It gives different, in fact I went inside today into this, it gives paralytic strabismus, comitant strabismus, restrictive strabismus. A person gets to do clinical examination of a patient virtually sitting at his own place of different type of strabismus. So, and this they did on 14 students, and they saw that there was a significant improvement in the strabismus assessment score from 22 to, from score increase from 15 to 22. So this is definitely 100% improvement in the clinical learning. So online there is CyberSite, there is AO. Orbis has a virtual mentorship where you can pay for one mentor of one subspecialty to take care of you throughout your next 2 years, and he would be teaching you all that is happening in his own country. And Ingenuity 3D training happens for surgery online in Armenian Eye Care project, but this is surgical. My topic is only clinical, so I have not included much. So in this all this world of digital learning of the clinical, can the technology replace our learning, what we had learned long back or what we as mentors can teach? Can the soft skills, but we have to remember that the soft skills can never be replaced. I think there is something which postgraduates will never learn from AI or technology, that is empathy, the lateral thinking and the problem solving ability. There was one child who used to come to me every 3 months as a headache repeatedly. I did an MRI, I did all the possible investigations, everything turned out to be absolutely normal. All it required was the probing of the child. One day I sat with the child for 15 minutes and the child opened up. Only when I say headache, my mom and dad stay back with me at home. So the child, when she used to crave for her parents, she used to complain of headache and she used to land in my OPD. So this lateral thinking, problem solving ability cannot be taught virtually. And the communication skill, breaking of bad news. This is something which really definitely cannot be taught by technology wise. And finally the counseling. When we do, as a pediatric ophthalmologist, when I do squint surgery, 100% there is 30% ratio of undercorrection, overcorrection. And when my postgraduate assesses, my fellow assesses it beforehand, how he conveys it to the patient about the underbar overcorrection is what is most important thing we need to teach them for their future. And these things can never be taught by any communication or by any technology. So these are, so to some extent in any clinical learning, us mentors or teachers can never be replaced. So our role still remains despite all the post-COVID technology. So with this, I would like to end with telling that for the PGs or fellows, tell me, they forget, they teach them, they remember. But when we get involved and they get involved along with us, that is when they learn. Thank you.
Thank you, Dr. Deepti, for that very informative talk. There were so many new things that you showed us. And what you highlighted in the end is that virtual teaching can never replace physical teaching. So one is the present day PGs are lacking in the emotional quotient, which needs to develop, and I think that can only be done when they are with a group and learning together with their peers and also with the teacher. And there's so many verbal, and non-verbal clues that you pick up when you're interacting with a patient, which you cannot never do when you're in a virtual mode.
Thank you.
Thank you.